Welcome back, everyone. In this part of the topic, we're going to cover these learning objectives. So be able to describe the mechanisms of regulating water intake and output, be able to define the term osmolality, be able to compare the processes and hormones involved in the maintenance of fluid balance and blood pressure, and finally, be able to list conditions of fluid deficiency and fluid excess. Now, we have covered most of this in a few topics, right? So I am going to go through this pretty quickly. So in terms of fluid balance, the volume of water in the body influences blood volume and blood pressure. And movement of water in and out of cells is linked to systemic maintenance of water volume by either one of two things. So directly adjusting water output. So here we're talking about excretion of high volumes of, dilute urine if you've taken lots of water in, or low volumes of concentrated urine when, there hasn't been any water available, or you're dehydrated. And indirectly by adjusting water input. So we are going to talk about thirst stimulation. So variations in water balance and blood pressure are detected by osmoreceptors. So those salt or saltiness receptors that are, detecting levels of sodium chloride in the hypothalamus and also the juxtaglomerular apparatus in the kidneys. And we also have those blood pressure sensors, so those mechanoreceptors or baroreceptors that are located in the carotid sinus, the aortic arch, the atrial walls, and the kidney juxtaglomerular apparatus as well. And when activated, they stimulate a response through the release of hormones. And here they come again, these three hormones. Antidiuretic hormone will increase water retention in the kidneys, also cause thirst stimulation, so we take in more water. Aldosterone increases sodium and water retention, and these two hormones act to increase our blood pressure. Atrial natriuretic peptide, or ANP, or atrial natriuretic hormone, decreases sodium and water retention to decrease blood pressure. We've talked about ANP, and that word natriuretic, is that old word for sodium, comes from the Latin, and it being the antagonistic hormone to aldosterone. So remember this triangle that we've shown in quite a couple of topics, looking at factors affecting mean arterial pressure or blood pressure. We talked about it in the heart topic, in the blood vessels topic, and now here we are down here in terms of fluid balance and the kidneys and fluid balance, regulating, the volume and concentration of urine, and therefore regulating the blood volume to regulate blood pressure. The higher the blood volume, the higher the mean arterial pressure or blood pressure, and then the lower the blood volume, the lower the mean arterial pressure. So body fluid balance can only be maintained if the intake is equal to the output of fluid per day. And the intake of water and electrolytes is rarely proportional. I mean, you're not measuring out, volumes of water to actually, be equal to the number of electrolytes that are taken in fluids and also in foods. So under normal conditions, the total water volume is maintained or restored by adjusting the urine volume, as I've mentioned. The kidneys can excrete excess water through dilute urine or excess electrolytes through concentrated urine. And they're the primary regulators of fluid homeostasis. And secondly, fluid intake, which is the secondary regulator of fluid homeostasis. Okay, so let's define this term osmolality. What is it? It's a measure of water versus solute concentration. The higher the solute concentration, the higher the osmolality. And in terms of plasma osmolality, it's the ratio of solutes to water in blood plasma, because we know the major component of blood plasma is water. So let's say these two beakers have, the same sort of solution. So they've got the same solutes in solution, but you can see that this one is far more dilute than this one, and they roughly have the same volume. So it will be the solutes in this solution that are making it more concentrated. So adding or removing water or adding or removing solutes from a solution will change the osmolality. When a solution has increased osmolality, that's going to trigger the thirst sensation and also antidiuretic hormone secretion. And decreased osmolality then will inhibit thirst and antidiuretic hormone secretion. So let's have a look at the mechanisms or the thirst sensation. So we've got a trigger, dehydration, right? Dehydration, loss of water from the extracellular fluid is going to decrease your blood volume and your blood pressure. At the same time, the decrease in the water content will increase the blood osmolality, so it becomes more salty, sodium chloride, right, relative to the volume in the extracellular fluid or the plasma. All right, so the thirst mechanisms. We've got here insufficient water in the body. It's going to decrease blood volume. It's going to increase blood osmolality. Remember those baroreceptors in the carotid sinuses, the aortic arch, they're detecting reduced blood pressure due to that decrease in blood volume, which is going to signal the hypothalamic thirst center. At the same time, we have those juxtaglomerular apparatus detecting low blood pressure in the kidneys, which activates the renin-angiotensin-aldosterone mechanism to produce angiotensin 2, which stimulates the hypothalamic thirst center. Okay, I'm going to go through this here. So we've got insufficient water in the body, increasing our blood osmolality. Okay, sympathetic nervous system is activated to inhibit saliva production, and that causes that dry mouth. Okay, we also have osmoreceptors in the hypothalamus. They're activated by this increase in blood osmolality. That's going to stimulate the thirst center in the hypothalamus to increase thirst. Okay, the decreased blood volume leads to a decrease in blood pressure. That will lead to the stimulation of the renin-angiotensin-aldosterone system. So that increase in angiotensin 2 will also stimulate the thirst center to increase thirst. We'll have a look at antidiuretic hormone on the next slide. It also stimulates thirst, and the combination of all of these things then activate thirst and will promote water consumption to decrease blood osmolality, and at the same time that will increase blood volume and blood pressure. So here's the bit about antidiuretic hormone. This should be very familiar to everybody. We've got a drop in plasma volume, and that will then increase the plasma osmolality. Detected by atrial volume receptors, stimulating the hypothalamus. Those hypothalamic neurons then fire, action potentials and cause the posterior pituitary gland to release antidiuretic hormone. Antidiuretic hormone then stimulates the thirst sensation to increase fluid intake and then increase the plasma volume. At the same time, it's also going to cause, water retention in the kidneys, which we'll look at now. Okay, so now we're going to look at regulation of urine volume to regulate fluid balance. Again, we've been through this a couple of times. So urine volume is determined by those two factors listed there: glomerular filtration rate. We talked about this in the last topic, except, under abnormal conditions, the glomerular filtration rate remains fairly constant despite, systemic changes in blood pressure. However, the rate of tubular reabsorption of water fluctuates considerably. And remember those distal parts of the nephron tubule system, so the distal convoluted tubule and the collecting duct, are under hormonal control. So antidiuretic hormone and aldosterone are secreted when water needs to be retained. So everybody should be very familiar with antidiuretic hormone and it causing water reabsorption in the kidneys. So when it is released from the posterior pituitary, travels all the way down to the kidneys, to the collecting duct, binds to those principal cells in the lining the collecting duct to cause the insertion of an increased number of these aquaporins, and these aquaporins then will allow for that rapid movement then of water through the cells of the collecting duct and then into the interstitial fluid into those peritubular capillaries, or the vasa recta. And of course then the net effect when antidiuretic hormone is sloshing around and inserting aquaporins into those cells of the collecting duct is to reduce urine volume, but to produce urine with a higher osmolality, to decrease blood osmolality, but also to increase blood volume and blood pressure. And this is just another way to look at it. We're just looking at the action of antidiuretic hormone in terms of renal water recovery, and we've talked about this, so I'll leave that one with you. And the renin-angiotensin-aldosterone mechanism or system should also be very familiar to everybody. So I'll just go through it very briefly. A decrease in water volume will cause a decrease in plasma volume and decreased blood pressure. The decreased blood pressure at the kidneys is registered, and that stimulates the renin-angiotensin-aldosterone system. Remember, angiotensinogen is made in the liver, it's inactive. It gets converted to angiotensin 1 via renin, and then angiotensin converting enzyme from the lungs then converts Ang1 to Ang2, and then Ang2 is a potent vasoconstrictor. It also stimulates the thirst sensation, but it also causes aldosterone to be secreted from the adrenal cortex. Aldosterone then, will cause the insertion of those sodium, potassium pumps into cells lining the distal convoluted tubule and collecting ducts to increase sodium reabsorption and potassium secretion into the filtrate, but also water reabsorption too. And angiotensin 2 also directly stimulates water reabsorption in the proximal convoluted tubule. So again, we're regulating the urine volume here to regulate body fluids. There's a summary slide here for anybody who's not quite sure about the antidiuretic hormone system or the renin-angiotensin-aldosterone system. This is looking at it in a different kind of way, but we're going to move on to look finally at fluid deficiencies and fluid excess. So just very briefly, everybody. Starting with fluid deficiency, volume depletion. The clinical name for this is hypovolemia, so low volume in the blood. So a decrease in total body water with normal osmolality. Okay, so there's many causes of this: severe blood loss or hemorrhage, or severe burns where there's loss of plasma, or chronic vomiting or diarrhea. Okay, so that one is there's a reduction in the blood volume with normal blood osmolality. Dehydration, though, is a decrease in total body water resulting in increased osmolality. Okay, there's many causes for this one as well: lack of drinking water, diabetes, obviously because of the high blood glucose levels, and that glucose sort of entering the filtrate and not being able to be all reabsorbed in the proximal convoluted tubule, will cause that glucose to flow out in urine, pulling water with it to cause the dehydration. Profuse sweating and the use of diuretics as well. Now, infants and the elderly are far more vulnerable to dehydration, and dehydration itself affects all fluid compartments. Now, babies are more susceptible to dehydration because of their small size, also because of their higher metabolic rate, and like babies can't communicate really, to tell you that they're thirsty, and they can't hydrate themselves. So they are more susceptible to dehydration. Similarly, the elderly as well, as we age, we tend to dry up a bit. So we have, less water fluids to begin with, like as we age. Also, our thirst sensation decreases, and many elderly people have, decreased renal function as well. So in terms then of signs and symptoms of dehydration, and this is sort of a descending list as, the dehydration gets worse. So initially there'll be thirst, and then nausea, then that, difficulty concentrating, leading then, further as, the blood osmolality is higher and higher, dizziness, weakness, muscle spasms, eventually delirium and kidney failure if it's not treated. Fluid excess is also a thing, and when we think about fluid excess, we often think about edema, so that tissue edema or tissue swelling. So with volume excess, there is equal sort of sodium and water retention, and this is also known as isotonic excess. It is most often due to hyperaldosteronism, which is a condition where there's oversecretion of aldosterone, and that will lead to too much sodium and too much water getting reabsorbed back, from the filtrate into the blood, leading to hypertension or abnormally high blood pressure. We also have something called hypotonic hydration, and where this is where more water than sodium is retained or ingested. The extracellular fluid then is hypotonic, and that causes water to move into cells to cause cellular swelling. You might actually use hypotonic hydration for somebody, if somebody is severely dehydrated and a clinician wants to sort of increase the total body fluids. So, or if somebody has been exercising very heavily in hot and humid conditions, they might have to have hypotonic hydration. The most serious effects of fluid excess, though, is obviously when it accumulates in the lungs to cause pulmonary edema, and also in the brain to cause cerebral edema. And just to finish up on this section here, we have fluid sequestration. Sounds like a big word, but it's sort of, just explaining accumulation of fluid in different regions. So edema is accumulation of fluid in the interstitial spaces. Hematomas due to hemorrhaging into tissues, and that blood then is lost from the circulation. And pleural effusions, accumulation of excess fluid in the lungs. You can have liters of fluid accumulating in the lungs from, bad sort of respiratory infections. And ascites then is a particular, type of fluid accumulation in the peritoneal cavity, which occurs, when the liver fails. So here's a little activity for you to do to check your knowledge.